So welcome. My name is Sarah Evans. I am with the Drug Policy Program at Open Society Foundations. One of the issues that I've been working on at Open Society for a few years is our internal collaborative effort on overdose in the USA, where, as you know, overdose statistics are horrific these days. And I've also done some work on overdose and particularly naloxone distribution in many countries of the world. So I'm really pleased to be chairing this panel here today. And the speakers will introduce themselves, but we have David, Nanao, Trish, and Pete. They'll each come up, make their presentation, and then, so I ask you to kindly hold your questions till the end, and then we'll take questions from the audience and have lots of time to, for your questions to the presenters, and also to hear comments that people might have about the situation with overdose in your country. So thank you very much.
Good morning. I would like first to acknowledge and honour the Wurundjeri people of the Kulin Nation for their ongoing care and custodianship of the lands on which we're meeting today. I pay my respects to elders, past, present and emerging, and honour their special connection with country. And I'd like to extend a special welcome to any First Nations people from around Australia and around the world today. So my name's David Baxter. I coordinate the naloxone program at CARMA. CARMA is the Canberra Alliance for Harm Minimisation and Advocacy. It's a peer-based drug user non-government organisation based in Canberra. So CARMA's existed under several different names since the early 1990s. We currently employ 13 permanent staff and several casuals and volunteers. Back in 2010, where our story begins, CARMA was a somewhat smaller organisation with just 4 permanent staff. CARMA's operations are largely funded by the Australian Federal Government and the ACT Government. And a bit of background, the Australian Capital Territory, or ACT, is a single city jurisdiction. It just has the city of Canberra, and Canberra has a population of just under 500,000 people. So naloxone is an opioid antagonist which is used to treat opioid overdose. Prior to 2012, naloxone was carried by ambulance crews throughout Australia for the treatment of opioid overdose, and it was kept in hospitals to bring people out of sedation. However, it wasn't generally made available to the public. And Australia had experienced very high comparatively high opioid overdose rates in the 1990s. In part due to a heroin glut, which saw very high levels of purity and comparatively low prices for street heroin. This was followed by a drought in the early 2000s, which saw overdose rates plummet. However, by 2010, high purity heroin was becoming more widely available again, and coupled with increasing prescription rates for pharmaceutical opioids, was causing increasing rates of opioid overdose. In response to this, CARMA and a number of other stakeholders in the alcohol and other drug sector established a committee called the Implementing Expanding Naloxone Availability in the ACT, or IONACT. And there was a fair bit of toing and froing for a couple of years about exactly how this program would look. CARMA is a non-clinical service. We don't have doctors or people who can provide prescriptions. As I said, we're a peer-based organisation. All of our staff have lived experience, and that is where we derive our strength from. And there was probably a very strong push to make the take-home naloxone program a clinical model, which is very top-down, where you have doctors will prescribe it, they might provide some kind of information or education around using it, but really it's not ideal for this kind of area for delivering harm reduction. We felt that a peer education model was much, much stronger, and that's what we ended up going with. And the centrepiece of the program was a 3-hour peer education workshop, which was delivered by CARMA staff and it trained people who used opioids how to respond effectively to opioid overdose, including administering naloxone. Now, on completion of the workshop, each trainee was provided with naloxone to take home with them, and after a year of lobbying, the ACT government finally came on board and agreed to provide funding to CARMA to train 200 people over the course of 2 years in overdose management as a pilot program. And that pilot program would then have its effectiveness and value evaluated by researchers from the Burnett Institute, the National Drug Research Institute and the Curtin University. So the first training workshop was run on April the 10th, 2012. During 2012 and 2013, a further 27 training workshops were held and over 200 people were trained and provided with take-home naloxone. There were 2 training workshops that were held in the Canberra prison, and each trainee was paid $50 then to participate in the evaluation process, where they were asked about their experiences, if any, in using the naloxone that they'd been provided, and they were quizzed to test their recollection of the training workshop and its materials. The evaluation of the INAC pilot program was released in August 2015, and it was overwhelmingly favourable, observing that a positive unintended consequence was participants reporting a sense of empowerment and positive emotional impacts associated with program participation. Both program participants and key stakeholders support the continuation of the program, and that was so important because we really wanted to continue this. We could see that this was saving people's lives, and it was improving people's lives. A lot of people, their first interaction with harm reduction services, apart from needle and syringe programs, was coming through the naloxone program, and we still see that at CARMA. So many of our clients, their first engagement they have with CARMA is through naloxone training. So in August 2015, CARMA started an ongoing take-home naloxone program with a designated trainer who was employed to organise and deliver the program, with the initial aim of delivering training and take-home naloxone to 200 people per year. The training workshop was shortened. Now, as I said, it was a 3-hour training workshop. That's pretty onerous. It's onerous if you're delivering the workshop on your own, and it's onerous for people who may not be terribly engaged or motivated to sit there for 3 hours watching a PowerPoint program. It's very, very easy for people to switch off, even more so if they're people of lower literacy, as some of our clients are. So we shortened it to around 1 hour, and the naloxone mini-jets that we had supplied during the pilot program were withdrawn from the Australian market, so we had to change to providing naloxone ampules, which involved also providing a kit with needles and syringes. Now, this was a problem in itself. Because of the particular stigma that is associated with injecting drug use, many trainees were understandably reluctant to carry naloxone kits around with them because it involved carrying around a whole lot of needles and syringes. And as with just about anywhere else in the world, police in Canberra would regard finding someone with needles and syringes, even if they've never been used before, as being probable cause. So if they find you with needle and syringe, they will take that as an excuse to arrest you, take you down, strip search you, things like that. So simply carrying them around could lead to bad outcomes. It was one of these things that we're really not happy about, but needs must. You know, if we're getting naloxone out there, this was all we could provide. That's what we had to provide. At the time, naloxone was a Schedule 4 drug, which meant that it could only be obtained with the doctor's prescription. Now, as CARMA's a peer-based non-clinical service, this meant that we had to have a prescribing doctor attend every training workshop to provide prescriptions for the naloxone that we're supplying. This was changed in 2015 to accommodate over-the-counter purchase from pharmacies, now only from pharmacies. However, naloxone obtained over the counter was considerably more expensive. You're looking at $50 or $60 a packet. In 2016, CARMA conducted a telephone survey of all the previous trainees, particularly people who had participated in the pilot program 3 to 4 years beforehand. 45 people responded to that survey, and the two most salient observations to come from that survey were that some respondents were not sure how to obtain replacement naloxone when their original pack had been used, given away or expired. And also many respondents felt that they would benefit from follow-up training or refresher training. So in response to this, we started providing what were called naloxone brief interventions. These are usually conducted one-to-one with the naloxone trainer, and the focus is actually on the administration of naloxone. So we're cutting down a full 1 hour training course into a 5-10 minute intervention. Now we can't focus on all of the things, all the first aid procedures and things like that we look at in our training workshop, but so long as people understand what an overdose is, what the risks are, and how to administer naloxone, and they know the importance of calling the ambulance. So we started providing naloxone brief interventions. The brief interventions were particularly useful for people who had already attended the training and didn't want to attend a full training workshop. They just wanted to come along and get themselves a new kit and maybe a little bit of a reminder of how to use it and what was involved with managing an opioid overdose. Throughout 2020 and 2021, the take-home naloxone... hang on. I've skipped a paragraph. In 2019, intranasal naloxone became available in Australia. Now, this was a real game changer. It was a watershed moment in Australian harm reduction. Many first responders who have no experience in using needles were uncomfortable about giving an injection, particularly as a first responder dealing with a medical crisis. Giving an injection when they have no experience of using needles, for a lot of people, is a bridge too far. And many AOD services were reluctant to engage with naloxone because it was only available as an injectable formulation. So with a lot of places like residential rehabs, they've got rules about having needles on site. So they couldn't have naloxone on site. And it's really important to have things like naloxone at residential rehabs because it's the people who are in recovery, who have been abstaining for a while from drugs, who are often at the very highest risk, and they're the people that we really needed to target. So intranasal naloxone was an absolutely wonderful thing. As a consequence of it, many other services in this space began asking CARMA to train their staff and clients in overdose management and the use of naloxone. And in late 2019, CARMA employed a second naloxone trainer to work outreach in the needle and syringe programs in Canberra, providing naloxone brief interventions. That year, 2019, also saw a considerable increase in the number of naloxone kits that were supplied through CARMA. Throughout 2020 and 2021, the take-home naloxone program was affected quite considerably by the COVID lockdowns in Canberra. For several months in 2020 and also for a period in 2021, we were unable to hold group training workshops, just couldn't be done. And this is reflected in the reduction of the number of kits that we provided during these times. You can see that 2019 we had 476 kits we handed out. 2020 it was down to 290 because we just weren't having that level of engagement with our clientele, and we weren't running big group workshops where you might have a dozen people or getting take-home naloxone at the same time. The introduction of take-home naloxone in Canberra's primary needle and syringe programs allowed community members who were unable to engage with CARMA due to COVID lockdowns. CARMA has also worked with the needle and syringe program providers to train their staff to provide naloxone brief interventions so that we don't have to have an outreach worker there to do the take-home naloxone. CAMA has also provided extensive naloxone training to other AOD and allied services over the past 3.5 years, and this has included people like corrections staff, other training organisations, tertiary nursing students, all kinds of people who have come and asked us for training around naloxone, how to administer it, how to recognise overdose, how to treat overdose. Last year, CAMA developed a naloxone training video. This was originally done as part of the response to COVID and the possibility that CAMA staff might not be able to interact face-to-face with clients for a period of time. In this case, the training video would be uploaded to CAMA's website and eligible clients could view the video and place an order to have naloxone delivered to their home. However, there are a few legal and administrative barriers that we have to overcome before we can go live with this service. So we have the naloxone training video, but we haven't been able to tie the take-home naloxone program. This is partly because we are funded by the ACT government and we are funded to provide naloxone to the ACT community, so we can't be providing large amounts of it to people from outside the Canberra area. As the take-home naloxone program in Canberra has evolved over the past 10 years, there's been a steady increase in the number of kits provided. Many of our trainees and clients have used naloxone to reverse overdose on multiple occasions. And in the last year, we've found that users of other recreational drugs such as methamphetamine, cocaine, ketamine and GHB are showing a greater interest in naloxone because of increasing media reports of street drugs being cut with fentanyl and other novel synthetic opioids. Take-home naloxone is now available for free from many pharmacies throughout Australia, and other AOD services in the ACT are now offering take-home naloxone. Despite this, CAMA still conducts overdose management training workshops at least 3 times a month in various locations throughout Canberra. In 2022, CAMA supplied more take-home naloxone kits than any other previous year, and the demand for this vital harm reduction service continues to grow. Since the start of the pilot program, CAMA has supplied over 4,000 naloxone kits to the ACT community through the overdose management training workshops, through naloxone brief interventions and through the needle and syringe programs. And at the moment in the ACT, we have around 10 to 20 fatal opioid overdoses every year. It's difficult always to measure how successful naloxone is in terms of how many lives might have been saved by it. But certainly, and this is one of the real strengths of peer education, is when I deliver the overdose management training workshops, is we usually have a 10 or 15 minutes at the end where we throw the room open and the trainees can talk about their experiences around opioid use, around overdose, what they've found using naloxone, and that helps to educate us as well. So, and this is one of the things that I think is really powerful about having a peer education model rather than a clinical model where the people who are providing the information are really not all that interested in hearing the feedback from their clientele. So thank you very much for coming along today, and I'll hand over to
Good morning, everyone. My name is Haobam Nanao, and people call me Nanao. That's more easier. I come all the way from India and northeast part of India called Manipur, and I work for Family Health International right now. So Manipur is a place, as you can see from the slide, it's have a population of about 3.5 million and shares an international border with Myanmar for about 300 kilometers. And we have an IDU population of about 34,000 as per ministry report, with a study which was conducted way back in 2019, by the All India Institute of Medical Science and the Regional Institute of Medical Science. So the estimated drug users were about 1 lakh, which is 0.1 million. So we have an area of about 22,327 kilometers square. So let's go straight to the gaps and challenges over the years. Severe penalties over drug users during the 80s and 90s by the law enforcers, insurgents, local clubs, anti-drug user organizations, etc. There were severe drugs. I myself, as a drug user, even I felt the heat of it. During the early 80s and 90s, the law enforcers sponsor people who are using drugs, paraded them on the road, like put them with water bottles around their corners and being paraded on the road, and some insurgent groups with their ambitious goal that they want to clean up drug use. They started people shooting over their thighs, but people never gave up drugs. So an anti-drug organization started beating up drug users. So it's all very challenging for the drug users way down. So OD cases are left to their own fate if not attended by family members. OD means death at that point of time, and if not the family member, there is no one else to attend it because of the high stigma and discrimination and all the sensitiveness that is getting along with overdose. So there was acute stigma and discrimination from the society at large and hospital setting. The only place where we could attend overdose at that point of time was the hospital. But there's always a ruckus over there when we take people over there to get overdose. People get recovered. The hospital people are always hand-folded and they never reach out. They always give statements that are very, 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 very hard to digest down ourselves. So it's all very challenging over there. Antagonist medicines not available over the counter and sold in an exorbitant price, taking undue advantage of the situation. Even that happens to me during my event of overdose. Well, when I asked my friend after I get recovered, and he told me that he spent around 8,000 rupees, that is near about a little less than $100 at that point of time, for one single overdose. And for an ampoule which costs only 100 rupees, there's just $1, a little less than $1. Police personnel at the hospital asked for bribery to get immune from charges. Death rate was high. Definitely death rate was high because overdose, as I mentioned earlier, if not the family attend, nobody is there to attend it. So death rate was very high. Common myths like administering of salt solution and dexamethasone injection, Decadron, which is commonly used as a steroid, was used as something by the drug user's friend or any other who come to rescue the overdose victim so that he can recover it. But these are all myths that has been going on for quite some time. There was no proper data recorded or available. There was no drug policy at that point of time. Where can I move? Sorry. So for the responses, slowly as we get over the 80s and 90s, during the late 90s, a harm reduction program named as REAC, that was Rapid Intervention and Care Project, which later on come to know as TI, that is Targeted Intervention Program, started around 1999-2000 under MSEX, that means Manipur State AIDS Control Society, being supported by NACO, that is the Indian government's undertaking, National AIDS Control Organization, NACO means. Some harm reduction programs like NSAP, condom promotion, abscess management, were incorporated with other care and support programs. But now at present, OST, that opioid substitution therapy, is also added in under this program. So slowly, with the support of this program, all those challenging, outreach workers and volunteers started to intervene, attended or reported OD cases by referring to the emergency unit at the hospital. It was still very challenging. Always a ruckus happens at the hospital when we come along with a overdose victim. So it carries on, but somehow things tend to get better. I'll come down the line. So antagonist medicines were still inaccessible over the counter, but exorbitantly under the decks, as how it happens to me, just the same. It was an agenda to discuss seriously among the users community and the TI implementing partners, although there has been no tangible solution or betterment. It was always a talk within the community that we should be doing something to respond overdose, because happening at least 2 or 3 overdoses comes as a service provider. We experience at least 2 or 3 overdoses in a day, say in a peculiar day. So the momentum is gained, but practical application of overdose response to OD was poor. So here comes an organization called SASO, which I was working at that point of time. This is the first ever users organization. It is you can expand it as a social awareness service organization. A community-based organization started responding OD through their TI project since inception amidst all the challenges that withstands. So we started responding to overdoses. Reported cases were attended with resources available within or referrals at the hospital. There were a little bit of naloxone that is being held by people who are working abroad at that point of time, some at Thailand and some at Belgium. So when we went and meet in conferences like this, they support us with a couple of boxes of naloxone, and with that we managed it in a very, very judicious manner. And other than that, we have to take it to hospital, which was the only solution at that point of time. So during that initial tough time, SASO has come up with the data. So this is not a very, very good data, but somehow we were able to gather a data from 2004 to 2014, where 1,126 OD cases were responded and 22 expired during this time. So within this, SASO has managed to attain 52% of it, and peddlers has managed it about 29%, and the NGO workers, or say other counterparts, managed 12% of it, and family members managed 6% of it. So under SASO's initiation in partnering with other like-minded TI implementing NGOs, rigorous advocacy sensitization programs were conducted for police personnel, local clubs, Maira Paibis. Maira Paibis are our language. These are mothers' organization who take care of the community by holding a torch in the night, a flame in the night. So we started, because they are one group of people who are very strong in the community, so we started doing advocacy towards them to support drug use issues and overdoses. And we started advocating. Sorry. And peddlers, public toilet keepers, community elites, hospital authorities, doctors, nurses, paramedics, educational institutes, schools, etc. about OD. Conducted training on OD management, discussion on central procurement of OD medicine, networking of OD response team, community peer-led model. OD response team phone numbers were displayed at the drop-in centers of STIs. So, continuing to respond, in 2016, SASO takes the lead of forming a community-led OD management team comprising of interested TI NGOs and other well-wishers working in drug use and HIV/AIDS. A WhatsApp group was formed in the month of April. The WhatsApp group is comprised of 24 individuals from various TIs operating across the state of Manipur as of now. The OD medicines Naloxone was centrally procured by SASO from a medical stockist and is further sold to respective TIs at MRP as per requirement, which is covered by their crisis management budget. Through repeated and intermittent advocacy and success, place antagonist medicines at some point of the major hospitals, CACs, and rehabs. The collective response of the community members with empathy and duty-bound 24/7 towards overdose is overwhelming by the rate of recovery and less death. The enhancement of social media incorporated with the dedicated response has put forth towards a human response. In any event of OD, the nearest operating TI will respond, and in case of any eventualities, SASO will be at the fore to intervene. On an average or a peculiar day, at least 2 or 3 ODs are reported in the WhatsApp group. So this is the figure which I will go. There was OD cases of 742 and expired 25, and OD cases of 206 and expired 9. So a total of 900 and something ODs and expired 34 during this period from 2016 to 16th March 2023. So these are age-wise region and district-wise distribution, which I quickly will go through as applicant. So positive response from the wider community and the government. Now, because of all the hard works we have done, phone calls, now we receive phone calls from the police and local clubs and the Myra Paibi, this mother's organization, public toilet keepers and individuals seeking help for suspected ODs. The Manipur State Drug Policy on Psychoactive Substances 2019 was published in the official gazette on 30th June 2020, where the link is given down below. And harm reduction is well incorporated, giving a boost towards OD management. Trainings are imparted to police personnel and local clubs as sought. So people started getting interested in OD things, and they started to want getting trainings on overdose. The OD response program has been replicated by many TIs and rehab centers and user community organizations. And now the last thing, the issues that pertains. Although heroin is the major drug abuse, mixing of WI, those are amphetamine type substances, and related overdose cases are issues that is going on right now. No proposed study or medicine for poly-drug use related OD cases as of now. With the ever-changing trend of drug use and substance orientation, there should be proper study and response mechanism, which is missing at this point of time. Needs more attention at the interior and hill districts. The only medicine for the moment is shown over here. It is Naloxone, produced by Wellona Pharma, that's in India. So thank you so much. Please don't leave a friend to die for a drug overdose. This is the DP of the Overdose Response WhatsApp group. Thank you so much.
Thank you.
Morning. My name's Tracey and I am from Turning Point, Scotland, which is a non-government agency in the United Kingdom. I'm going to speak to you today about our rapid response to near-fatal overdose across 2 health boards in Scotland. Now that's 8 alcohol and drug partnerships. So that's 8 different areas with different funding streams that we tried to come together to have this response. Okay. Turning Point Scotland operates in all the purple areas of Scotland, and our largest part of our organisation is working with people with learning disabilities, but also people in homelessness, justice, mental health. And actually we find that a lot of people are the same, and we can share our learning and our understanding with each other and take good practice from each of our works, which has been really helpful. Sorry, I'm not doing very well with this PowerPoint. So Scotland, we have a population of about 5.5 million, so we're a small country, but we have a major issue with fatal overdose deaths. We have the highest drug overdose deaths in Europe, and probably the next is America and Canada. We don't have fentanyl available in our area. It's heroin and injecting cocaine and benzodiazepines. Lots of polydrug use, lots of different substances combined together, and lots of injecting, especially with cocaine. But we have a very stifled voice for our drug users. We don't hear much from active drug users in our community, and trying to empower them has been quite a challenge. We have large numbers not in treatment. We do have a methadone programme and lots of other medication-assisted treatment programme available. We have Naloxone readily available. We have a good health service, but our services are not always welcome to the people that we should be servicing. They're not always there at the time that they're needed. We work very much 9 to 5, Monday to Friday. So in 2019, we set up a drug death task force in Scotland. And one of the first jobs it did was to ask frontline workers, what is it you think would make a difference? Because this is a big issue, and we're feeling a bit powerless about what to do that, because in Scotland we have devolved health policy, but we don't have, our drug laws are still with the United Kingdom. So the frontline workers in Glasgow and the areas surrounding Glasgow met and had a discussion about what they thought would work. And they felt that we should have a test of change. The Drug Death Task Force would fund for initially a year, this then put on to 2 years. And what they felt was we should have an assertive outreach approach. We should have voluntary sector workers going out, harm reduction into the community, working from 10 in the morning to 10 at night, 7 days a week. And this is really different because most of our services, I say, were Monday to Friday. It's going out and finding people that we could get the information about when somebody's had a near fatal overdose, and we could go look for them. We go find them in their communities and take that service to them and just show them that they're cared for, that we are interested and have had this trauma in their life and that we want to help. And that'll be whatever it is they want that help with, but taking that to them. We also would deliver harm reduction, bring naloxone, take naloxone to families and anyone else that was around there, and try and make them aware that they've had an overdose themselves, because sometimes that wasn't known. So the idea was to take our Scottish ambulance data. So in it went an ambulance, the data would be given over. We could then get the names and go and find people. But we knew there would be some issues with that via information sharing, so we also had a free phone number so that anybody could phone that line and give us information. We kept the information you had to give very simple. As long as we had a name and an address or a phone number, or even just a name and a phone number, we would try and find somebody. We also took referrals as well from police and different partners. So we were so passionate about this response, so we wanted to really look at whether this worked, because we wanted to empower the frontline workers and people with living experience that really contributed to this idea. So we employed Indigo House, and they did a mixed methods independent evaluation. They were looking at whether the service was making a difference to individuals' outcomes, to see if we could actually find people, and if people would engage. Would people want somebody to come to their door once I've had this event? Would the door be slammed in our face? Would we be told to go away because it was a risk that it could have happened? They also wanted to know what would make a difference to information sharing. Would that information be shared with us as a non-government organisation? Would partners be willing to work together to make sure that we all have a joined up approach? Because although we were outreaching to individuals, we needed all the services to then work with that individual. There was interviews with key stakeholders, with people who used the service and their family. And the interviews with key people that used the service, I thought would be difficult because we only worked with people for short periods of time, but actually people were really quite willing to talk to us, the researcher, and to follow up again actually 6 months' time and give more information. So the key findings that the evaluation found was that the out of hours and weekend work really mattered. People really responded better at daytimes, particularly in the morning. We find that people don't turn up for appointments, so actually going out in the evening when people maybe have done other things for their day and going out at the weekend. Also just being person-centred, holistic, listening to the person when we went out to the door and finding out what they want. And for some people, that was about helping them with their heating or helping with housing. For others, it was trying to get them into a medication-assisted treatment programme. Whatever it was the person wanted, rather than going out and offering a whole host of things, we were listening. We did have injecting equipment with us as well, and naloxone. But what was really important was that we got to that person one of the key findings was that they got to the people really quickly. If we went 2 weeks late, if our data was delayed to us and we went 2 weeks later, often engagement wasn't good. When we got there within a couple of hours, or 12 to 48 hours was what we aimed for, but sometimes we were there 2 or 3 hours, the response was much, much better. And the approach that we used was to be really quite persistent, to be assertive, consistent, motivational, imaginative and dynamic. They're all quite good fancy words, but really just getting alongside people and keep trying. We sometimes travel an hour to someone's home and they're not there. We'll go back out again a couple of hours later. We'll talk to people in the community, we'll talk to services that are maybe known to, and find out places they will go, and we will go look for them. And so one of the things was that approach really worked, really helped people get engaged. We also found that deaths were prevented, that people were found engaged, and 61% were doing better. We also helped people connect with their families. We also found we had someone help us to set up this service, somebody with living experience who was still using, and when he was coming to the meetings, he was really contributing really well. But he turned around in one of the meetings and said, didn't know what an overdose was. Actually, this was a problem that we have in Scotland, that often people don't actually know they've had an overdose. So we had to make sure that we make that more explicit and explain that to an individual. Somebody goes to the hospital, but then when we go out, they don't necessarily know what they're in hospital for. So it's trying to connect how that has impacted in their life and that trauma, and help them. They are valued and their life's important. And also we were concerned about going to people's houses and how that would be received. But actually some of the feedback in the evaluation report was that people felt cared for, that they felt nobody cared, they left the hospital, didn't have any follow-up. Okay. The findings also found that there was obstacles to overcome. Information sharing. Scottish Ambulance Service did share information, but they shared it with the Health Board, not with us, because we are not a government organisation. That information then had to be relayed to us, which gives us a time lapse, which is really, that then delays that quick response that's really needed. They also found professional wariness. That often people were unsure, professionals were unsure in medical services about working alongside. So we worked really hard to break some of that down, it's still there. So the recommendations from the evaluation was that every area should have one of these assertive outreach services, and that they should be out of hours. We do have some of these services throughout Scotland, but they're not necessarily out of hours and weekends. And also that collaboration works. The reason that some of these worked was we had funding from the government to cover a number of areas. Unfortunately, the way that the funding is operated is everybody gets a small pot, and it's really difficult for them to work together, which means that they can really only do time-limited services rather than doing that 7 days. We also need to break down the cultural barriers of professional awareness, address structural barriers, and there was also a recommendation about greater capacity within the workforce. This was a test of change, so as it was coming to an end, many people had moved on, and obviously that was difficult. Okay, so the idea is not complicated, it's really quite a simple one, it's going to somebody quickly, but it's not necessarily easy. And it's often all the structures that get in the way. So it does need a whole system a response, and everyone to work together. Thank you very much. Is there on that link if anybody wants to read it.
Good morning. My name's Peter Davidson. I'm an associate professor in the Department of Medicine at the University of California in San Diego. I've been doing research around finding ways to reduce overdose deaths since 1997. I'd be old. Originally here in Australia at Endry in Perth, and since 2000 in the US, mostly in California. What I want to talk about today is the Naloxone-on-Release program in the Los Angeles County Jail System. Naloxone-on-Release isn't particularly new or innovative. It's not particularly widespread yet, but the unique thing about the Los Angeles program has to do with its scale and its low threshold nature. And so I want to sort of describe that in the hopes that it will be useful for people either trying to start this kind of program or scale up existing programs. In the United States, jail systems are managed at a county level, and they hold people who are still awaiting trial or people who've received sentences typically of less than a year. People who get sentenced to more than a year are usually transferred to state prisons, a completely different system. Los Angeles has a population of about 10.3 million people. It's by far the largest county in the United States. It's bigger than all but about 9 states. And its jail system is, as a consequence, also the biggest one in the United States. It has an average nightly population of 17,000 human beings. And they release about 5,000 people every month. So it's a pretty huge system. Los Angeles at the moment has somewhere between 1,500 and 1,700 overdose deaths every year, mostly driven by fentanyl and exacerbated by COVID. About 10% of those deaths are people who've come out of the jail system within the last year. So around about 150 to 170 people a year are dying who are recently in the jail system. So my co-author on this presentation, who unfortunately couldn't be here, Shoshana Scholar, used to run one of the bigger community-based needle exchanges in Los Angeles and then transferred to working for the county and became our secret harm reduction spy inside the county system. And in that role, she managed to leverage the state naloxone system to start distributing about 60,000 doses of naloxone a year in LA. And back in 2017, she and I started talking about doing a Naloxone-on-Release program. And part of the reason for that was the obvious one, that people coming out of jail are at super high risk. But another part of the reason was that some recent research done by some other colleagues of ours looking at community distribution of naloxone in San Francisco and Los Angeles found that people of color who used opioids were much less likely to get naloxone from community programs. They were less likely to have it on them, and they were less likely to be able to get refills after they used it. In Los Angeles, as in everywhere in America, people of color are very, very, very disproportionately the people in the jail system. So we wanted to kind of attempt to make use of that to find this way of delivering as much naloxone as we could to people who were underserved by the existing community programs. And we were sort of lucky in a couple of ways. The jail, which is operated by the Sheriff's Department was under a lot of political pressure at that point because there were a lot of deaths going on inside the jail system. In addition, our fantastic Scottish colleagues chose that particular moment to publish a paper showing the efficacy of their national level Naloxone-on-Release program. And they found that in the 3 years after they introduced the program, there was a 36% drop in the rate of overdose deaths in the 4 weeks after release compared to the 3 years before the program was started. So it had this huge impact on death immediately after incarceration. We also had some survey data from the Sheriff's Department itself, which found that about a third of the people entering the jail system said they were interested in receiving naloxone. So armed with all that evidence, we were able to go to the Sheriff's Department and sort of talk them into doing Naloxone-on-Release. Shoshana and I then went and visited a couple of the jails in LA, and our original idea was to sort of replicate a small program that exists in San Francisco where people who opt in to receiving naloxone, when they move to the release pod, the housing they're in immediately before release, would participate in a small group training, and then naloxone will be placed in their property, so they had it when they were released. And it really quickly became apparent this was just not going to work in LA. Firstly, that required the Sheriff's Department to actually put naloxone in people's property, and the Sheriff Department didn't want to do that because that would mean they would actually have to do something. Secondly, we had this huge scale problem. I mean, 5,000 people coming out every month. You know, even if we only provided this to people who opted in, there was just no way we could do that many small group trainings. And we were already kind of didn't want to do this opt-in model anyway. We knew perfectly well that people have really, really good reasons not to say, oh yes, I would like naloxone, please, because that outs them as someone who uses drugs or someone who's adjacent to drug use, which is not something you necessarily want to do while you're still incarcerated. We didn't want to restrict it to people who'd only been charged with drug offences because, again, people who use drugs or people who are around people who use drugs are often arrested and charged for completely different things. So the other thing we noticed as we were going around these various hideous jails was that everyone in LA gets released through 2 rooms. There's 7 facilities across the county. There's 1 women's jail, about 10% of the jail population's female, and 6 male facilities. The women's jail, everyone who's being released gets moved into a single release room and released from that facility. For the men, they all get transported to Men's Central in downtown Los Angeles and released through a single room. These rooms, if I can make this thing work, there we go. It's sort of a large room, there's a bunch of stainless steel seats, and there's a single window up against the wall. They move people in, about 20 people at a time. Everyone takes their turn to go up to a window and do their paperwork, and then the buzzer goes off, the door opens, and people walk out onto the street. So in that room, we put a couple of videos up above the window that everyone was already watching pretty intently. There's a 7-minute video which goes over here's how to prevent overdose, here's how to recognize it, and here's how to respond to it with naloxone. And at the back of the room, whoops, too far. There we go. At the back of the room, we put a vending machine and filled it full of naloxone. And you can go up and push the button as many times as you want and get as many boxes of naloxone as you want. The Sheriff's Department really, really, really loved this model because it meant they had to do literally nothing. The vending machine is refilled by a community-based organisation that Shoshana used to run. That's Shoshana, by the way. And they could just put out press releases talking about this amazing thing that they were doing without having to do anything. So they were happy. We had no idea how this was going to work or whether it was going to work. We loaded the machine up on January 1st of 2020, and by the end of that year, 30,000 doses of naloxone had gone out through that machine. We did some ethnographic observation in the months immediately before COVID lockdown started, and I saw things like someone would go over to the machine and they'd look at it and they'd suddenly realize what was going on, and they'd stand up on one of the stainless steel benches and they'd start shouting at everyone else that they all needed to get their asses over here and get some of this stuff, and it was really important, and everyone would shuffle over and take a couple of boxes. People would walk up to the windows where the deputies were and point at the boxes and mouth thank you through the window. It was pretty intense. We've given out about 30,000 doses every year since then. One other thing that the sheriff has done since then is deputies on the housing units have been equipped with naloxone for several years because they keep having overdose deaths there. But we convinced them that they should put naloxone in the units so that people could use them themselves, because people were often delaying calling for help for really obvious reasons. That's worked in the absolute sense that that people have actually used naloxone to save each other. One of the things, in some ways it may have actually backfired. We've been interviewing people as they come out of the jail, and sometimes people say, who haven't taken naloxone, say the reason they haven't taken naloxone from the vending machine is, oh no, I don't want to touch that stuff, because one of the things that happens when the people use the naloxone in the housing units is all hell breaks loose. All the deputies show up, all their property gets torn apart. And so they've come to sort of mentally associate naloxone with this really intense law enforcement response. And we don't really know what to do about that. We can't ethically say we should take the naloxone back out of the housing units because it is being used to save people's lives. And we can't convince the sheriff to do something different about what happens when there's an overdose on the pod. So we're kind of stuck with that one. And if anyone has any thoughts, I would really welcome them. In conclusion, this has worked really well. It's super low threshold. Like, anyone can take this stuff. They don't need to opt in. It's happening when technically and legally they're already free. They're just waiting for the door to buzz open. And it scales amazingly. Like, we have this gigantic system and we can pump out tens of thousands of doses of naloxone every year, no problem. And we're doing it with almost no resources whatsoever, other than a lot of state-funded naloxone. Thank you very much.
Thank you, Pete. And thanks, let's give everybody another round of applause before we get started. So that was a lot of information. We heard about the work in Australia, groundbreaking work with peer-led naloxone distribution, and the troubles that you were encountering with police with the needles and the switch to the nasal formulation and the impact of that. We heard about the WhatsApp group in Manipur, which saw deaths decline from, I think, 725 before to 9 afterwards. We heard about the assertive outreach program in Scotland, which was intervening in near-fatal ODs, following up with people, since having a near-fatal OD is a big predictor of, in future, potentially having a fatal one. So that intervention to prevent fatal OD in the future. And then this Naloxone-on-Release. So we have David, Nanao, Trish, and Pete. And I just want to invite questions from the audience. If you have a question for a particular speaker, note that, or for the whole panel, note that. And also comments about the situation of overdose in your country or where you live. And while you're gathering your thoughts, reminder, PSA, that Eliza, sitting right here, has intramuscular naloxone in boxes, and if you need some for your own purposes or to take with you, please don't hesitate to hit her up at the end of our session. Yes, way back there in the corner. Please come up to the mic if you can, or this nice person in the orange shirt will bring a mic over to you.
Hi, I couldn't get further away, but I'm also from Perth, Western Australia, which is the furthest capital, where the most isolated city in the world. So that's our claim of fame. So to the last speaker, is that Pete? Yeah, I got a little bit lost at the end when you were saying that people were in the housing units, and if they use naloxone and like the sheriffs and everything would come. I missed a little bit of like the using and then them arriving. Like, how would they know?
Right. Pete, we'll just hang on for one sec, just in case there are other questions. Do we want to bundle a couple of questions? If people have, raise your hand if you have a question. Let's just take 2, and we'll just get the dialogue going. And Pete can write his notes to answer. Thanks.
Thank you. I'm Chang from SCDI, an NGO in Vietnam. So we are also implementing a peer-based naloxone distribution and overdose rescue in the provinces that we are implementing. So very inspiring, the work that you are doing. Congratulations on the good job. I want to have questions, first of all, for Patricia, because the way that you said it's assertive outreach work. So I am wondering about the communication scheme that you are doing right now, so that people know more about the free phone numbers, so that they can call you afterwards. What have you been doing on communication so that people know about your program and rescue more people in need? My second question is that you share about the poly-drug use issues in your country, in Scotland. So is there any harm reduction additional interventions that you are doing after the overdose rescue so that you can address the poly-drug use issues? My third question for Patricia is, you mentioned in the last slide about the people stopped or reducing the use after the intervention that you are doing. I am wondering how you are doing that, what type of intervention or counseling that you provide that get you to that result. And the second one on that is a monitoring system that you do so that you can monitor how people stopped using or reduce using. because it is not what we witness in Vietnam. We have seen people overdose 4 to 5 times with constant counselings and support afterwards. Sorry for too many questions. I am still have one question for Pete.
Go ahead, Trang. You're fine.
Apologies.
Go ahead, Trang.
What you are doing on Naloxone-on-Release is very inspiring. We have been trying to work with the compulsory detoxification centers in Vietnam for a while to have a communication session where we bring the community-based organization to come and talk about overdose risk, so that when people get out, people can access to naloxone and overdose rescue in the community-based organization, but outside of the centers. So what you are doing is really inspiring. How are you set it up with the stations, something like that, so we can have some inspiration to work on that from outside, because something low threshold is very important that people can get it right after they went out. And we cannot do a lot of communication session. We want something to stable in the detoxification centers. So very curious to learn about that.
Great. Thank you, Trang. No, you're fine. Thank you. So let's go first then to Pete. You could answer the question for the person on the back about what actually goes on in the pods.
Yeah, it's pretty straightforward. The boxes with naloxone are connected by cables to the guard center, so when someone pulls the lid off, they get alerted straight away. With respect to how do we get it to people being released, everyone's sort of going through this bottleneck of the release room, so they all go past the intervention, so to speak. In that respect, we had a very easy situation. I hope that answers the question. And we can talk later if I didn't.
We might come back to the compulsory detention question a little bit, because I think what Trang is also asking is about the negotiation. Yeah. Like, it's very hard for them, for SCDI, I know this because I worked with them as a community group, to negotiate with the people that are running these compulsory drug detention centers, these re-education centers to Vietnam. They're not interested in, even you made it easy for the sheriffs, but that's not enough. So we might come back to that question. But Trish, a bunch of questions for you about assertive outreach.
Again, I'm happy to talk to you later. I'll try my best to answer the questions. How we communicated our free phone number and how we are available was we spent time in the communities. We went to family groups, we went to places where people were, and we promoted the work that we were doing. So we just made sure we were present and we were known by people, so that people knew and trusted us, so that they could then spread the word to others. Of course, we did put out on social media, we did do flyers, we did go around all the agencies, but actually that community work was really important. And also because we're doing assertive outreach, when we're responding to somebody's home, we're in that community as well, we're speaking to people there, and that word is then spreading. I think that was your first question. The second question was about poly drug use and harm reduction. We can refer people into treatment for their opiate use. We also, in some areas, can get benzodiazepine stabilisation doses as well. Not everywhere, but in some areas we can do that. And the rest is just giving advice, about using slowly and safely, and so that harm reduction messages for all the different drugs. Yeah. The good responses, this was the evaluation that found this response, and it was quite surprising. But we also found that some people were coming back, some people were having more overdoses. I mean, we know just from word of mouth that we lost some people as well. But we were surprised that when the evaluator went back, that was a self-report that people were doing better. And they were obviously feeling better. What that meant, I'm not exactly sure. It doesn't necessarily mean that everybody was abstinent, just that they were doing better. We do know that a lot of people didn't have another overdose, which was really, really quite useful, but some people did. Yeah. I think so.
Thank you. Any other questions from the audience? or comments? Yes, please.
Hi everyone, Dan Winter from University of Sydney. First, thank you everyone for those wonderful presentations. Probably one of the things I find with overdose prevention awareness and distributing naloxone is the sometimes, dare I say, onerous regulations that are put in place. I was talking to some colleagues from the US last year at a conference when we were talking about the Australian experience of naloxone distribution. They often were quite shocked at how much regulation and requirements were behind, the distribution. And I think it's probably as best put by, if I could dare plagiarise Patricia's, one of her slides where she said, it certainly is not complicated, but it's not easy. We know that this is a life-saving, simple medication, and yet sometimes I find that the barriers put in place can just be a bit insurmountable. I guess the question for the panel then is, in your experiences, in your own jurisdictions, what do you think you guys have faced in terms of that? And perhaps, is there anything you'd love to change if, you had the opportunity to do so?
Thank you. Really great question. Yeah, so that's a question for all the panelists, right? Despite the fact that people have been distributing naloxone in the community freely since the 90s and the WHO issued guidance on it in 2014, it's still so hamstrung by many different regulatory and cost, I'm ad-libbing here, but cost barriers, right? And so, yeah, like if you could change something to make it more available in your communities, what would you do? We can just go down the road, like David, not to put you on the spot, David, but do you want to take that question first?
Yeah, so I spoke about it briefly in the presentation, was back in the day before 2015 when naloxone was dual scheduled in Australia. We needed to have a doctor come along to all of our training sessions. All of our naloxone had to be provided on prescription, and because we're not a clinical service, we couldn't write those prescriptions, so we had to really have a doctor come along, which meant arranging a time with a doctor to come and prescribe the naloxone. It also meant that the doctors had to satisfy their own criteria to provide naloxone to our punters, to our clients. And in some cases, it was really quite difficult to get a doctor, and there are occasions where the doctor would cancel at the last moment and we would have to stop the workshop. When they brought on the dual scheduling in Australia, that made our job so much easier because it meant that we could stockpile the stuff on site. Now, it cost us a lot of money, but it's not our money, it's the government's. And we can provide it as we see fit rather than, having to go cap in hand to a medical service and get them to do some of our dirty work for us.
Thank you. I don't know, Nanao, if you have some comments, like what is it that if you could have one wish to remove regulatory barriers or make it more accessible and more affordable, what would you do?
Listening to all these comments and the opinions that has been given here, it's completely a different scenario out here in our place. Like, there's only a small budget in the program that TI, which I mentioned, a budget of around 1,000 rupees only to manage this critical situation of
1,000 rupees for a vial of naloxone?
No. That with that much budget, every TI is trying to manage. Yeah, one ampoule of naloxone costs 100 rupees,
which is $1.
Yeah, which is $1.
Like approximately.
So with that, about $10 in a month for each TI, they are trying to manage with that.
And the TI is the technical assistance group, right?
Yeah.
Yeah.
So the situation is very much not in a good position right now, but it's coming up slowly in spite of all the hindrance that has been faced in the past and where overdose is almost equal to death. So things are improving, but they've still got a long way to go. So that much only.
Thank you.
Okay, for me, I think I'd like to see an naloxone available in public spaces, so that maybe having nalox boxes where, in the community where people can access it. So if you're not getting a naloxone kit with you, or if you're just a member of the public, you can follow instructions. So rather than it being that everybody has to be trained and take it with them, there's accessible information and a naloxone kit there, and they're throughout the community for people to be able to access.
Yeah.
I think I'd say two things. I mean, the US is in a pretty good position these days compared to what it used to be, but for a good 10 or 15 years, most of the naloxone distribution in the United States happened with naloxone that conveniently fell off the back of a truck and was just given out in somewhat grey legal circumstances. And, we saved 20 to 30,000 lives doing that. So, drug users are really good at finding and getting their hands on drugs they're not supposed to have. You can do that with naloxone too, and I want to really encourage you to just give out naloxone and find a way to do it. If I was going to change one thing about the regulatory environment in the US at the moment, we have this system of state block grants, and they give out big block grants to states to respond to the opioid crisis, and a lot of states do things like, well, we don't know how to work with people who use drugs, so we're going to give it all the naloxone to cops or other groups who aren't actually going to be there when people are overdosing. And if I would change one thing, it would be make it so that naloxone just goes to people who use drugs.
Yeah, here. I think we might have time for another question if there is one. Otherwise, we'll go to closing comments from our speakers. Right. You might have just given your rousing speech, but if you want to...
I'm done.
You're just give out naloxone, give it to people who will witness overdoses, the end. Okay. Trish, any closing comments from you?
I think we need to go back to that whole system response, that it's everybody's responsibility, that we all need to work together and just, respond and be compassionate to people. Yeah, and I think getting people access to treatment as well, being able to respond to somebody with naloxone, but what's next? And how do you then make them feel valued and want to live and want to move on?
Thank you. Nanao, do you want to make any closing comments?
Yeah, thank you all very much for listening to me. Yeah, with all the supports around, I think we still can go so much ahead, because in spite of all the struggles that we faced in the past during the 80s and 90s, we already have a policy in our hand, and it's going to be implemented very soon by the government. So with that, many promising things can be happening. So with all that, we need to at least capacitate the users, and most of the service providers, or 80% of all the TIs, are ex-drug users or current users. So we need to capacitate them in all possible ways, so that we can move forward with overdose response in a big way. That's all. Thank you.
Thank you. And David?
Yeah, I don't really have much to add, but, where we are is still only just the beginning. It's not just providing a harm reduction service right there. That's okay. We've dealt with the problem. Overdose is going to continue to be a problem, and it's going to continue to cost us lives and so forth. So the more naloxone we can get out there in the public space, in amongst people who use drugs, but also in amongst their friends, their families, the people who live with them. The more we get out there, the more lives that will be saved.
Thank you. So let's just thank our speakers one more time for these presentations. And if you need naloxone, Eliza's sitting right there.